This image marks the beginning of a relatively challenging section on antidepressant medications. There are a wide variety of meds on the market right now for the treatment of depression. This schematic attempts to point out the different mechanisms of action of many of the similar medications you may see on the boards. As we work through the rest of the sections on the next 2 pages, keep referring back to this picture as your guide to understanding how to think through the similar but distinct mechanisms of each of these drugs. The goal the whole way through is to increase the concentration of norepinephrine and serotonin in the synaptic cleft. As you may remember from earlier in the chapter, when we discussed patterns of neurotransmitter changes in different psychiatric illnesses, most all neurotransmitters are decreased, or depressed if you like, in concentration in depression. Therefore, increasing their concentration is often the goal of therapy. Generally speaking, there are 2 different types of neurons that are affected by antidepressant medications: the serotonergic and the noradrenergic neurons. Let's start by looking at the serotonergic neuron. As neurotransmitters are released from the presynaptic neuron into the synaptic cleft, in the direction of the postsynaptic neuron, they can either bind to the receptor itself, or they may get taken up by the presynaptic neuron yet again to either be reused or metabolized. To increase the concentration of serotonin in the cleft, medications such as SSRIs, trazodone, and tricyclic antidepressants block reuptake of serotonin, allowing more to remain in the synaptic cleft. Another way to increase the amount is to block the metabolism of serotonin after reuptake, which is accomplished by the MAOIs, or MAO inhibitors. If you now look at the noradrenergic neuron, there is a similar analogy to everything we discussed from the serotonergic neuron. To block the reuptake of norepinephrine, you can use meprodoline or tricyclic antidepressants, which block the reuptake of both NE and serotonin. MAO inhibitors also work to block metabolism of norepinephrine as well. Another distinct mechanism of increasing concentrations of norepinephrine is via the action of mirtazapine. Mirtazapine blocks alpha-2 receptors. Normally, alpha-2 receptors would decrease presynaptic release of neurotransmitters, so blocking the alpha-2 receptors with mirtazapine causes an increase in the concentrations of NE in the synaptic cleft. That may have felt like a lot of info, but make sure to keep going back to that picture to help you keep the mechanisms of all these similar meds straight. Keep in mind that the names of the drug classes often give you a clue as to how they function, so if you understand the name, you can easily remember the mechanism. So now let's focus some time on learning the details of each of the drug classes, or specific drugs we spoke about in our schematic. The first of these is the tricyclic antidepressants. While these aren't necessarily the first line, they are among the oldest and best studied drugs in psychiatry. Because they're so old, there are a ton of them, and they don't follow a great naming convention. The drugs are imipramine, amitriptyline, desipramine, nortriptyline, and so forth. They're a bit tougher to keep straight, but I like to remember that they all contain either ip-ene or oxine in their names, and that most of them end in either iptyline or ipramine. TCAs block the reuptake of both norepinephrine and serotonin, as we showed in the previous diagram. Their clinical uses are relatively broad, starting of course with depression, all the way to fibromyalgia. Specific ones also have certain additional clinical indications. Clomipramine can be used to treat obsessive-compulsive disorder, as we discussed a few minutes ago. Additionally, imipramine can be used to treat bedwetting. During what stage of sleep does bedwetting occur? The answer is back in the behavioral science section. It occurs during stage 3, non-REM slow-wave sleep. While these drugs are considered to be effective for the clinical indications, the major drawbacks to their use is their pretty awful side effect profile. They cause sedation, alpha-blocking effects, and most importantly, anticholinergic effects. The third-generation TCAs, like amitriptyline, have worse anticholinergic effects than the second-generation ones, such as nortriptyline. While anticholinergic side effects may simply show up as tachycardia or urinary retention, which may be more benign, elderly patients may actually suffer from hallucinations as a result, so it's particularly important to use second-generation TCAs for this reason. With overdose, you get the tri-Cs: convulsions, coma, and cardiotoxicity. This is usually in the form of arrhythmias. You can also get hypoventilation. The tri-Cs, as well as the other side effects of this class, show up a lot on test questions since they're fairly unique among psych drugs, so memorizing them is pretty high yield. TCA overdose should be treated with sodium bicarbonate. This alkalinizes the plasma and helps neutralize the active byproducts of TCAs. The next drug class is among the most high-yield drug classes you'll need to learn for the boards. SSRIs, or selective serotonin reuptake inhibitors, include fluoxetine, paroxetine, sertraline, and citalopram. The mnemonic that those of us on the first aid team came up with to remember these was Flashbacks Paralyze Senior Citizens, a reference to their use in post-traumatic stress disorder. As you might guess from the name, they block reuptake and recycling of 5-HT or serotonin at the bouton. Clinically, they're used for a wide spectrum of diseases, including depression, OCD, bulimia, social phobias, and post-traumatic stress disorder. Keep in mind that this is only a partial list, as we saw earlier that there are many other possible or relative indications for them. In terms of toxicity, SSRIs are considered an advancement on TCAs. The predominant ones to know about are GI distress and a characteristic sexual dysfunction, which is a major reason patients want to stop taking them. Two classic questions you may also see relate to a side effect and a pharmacological feature of this class. The side effect to know about is serotonin syndrome. Basically, if a patient taking SSRIs also incidentally takes a medication that also increases serotonin concentrations, for example MAOIs, they'll manifest with symptoms of serotonin syndrome. Think of it as a sort of neurotransmitter overload. This presents with hyperthermia, muscle rigidity, cardiovascular collapse, flushing diarrhea, and seizures. The first half of this entity may sound familiar, particularly the hyperthermia and muscle rigidity. You guessed it, it does sound somewhat similar to neuroleptic malignant syndrome, but the vasodilatory effects of serotonin add another key feature to serotonin syndrome, and that's flushing and cardiovascular collapse. The treatment is prompt administration of cyproheptadine, which is a serotonin receptor antagonist, specifically 5-HT2. Can you recall another 5-HT2 receptor antagonist that we recently talked about? That's right, the atypical antipsychotics. In fact, severe cases of serotonin syndrome can be treated with olanzapine. Now, I said there were two boards relevant facts that are classically asked about SSRIs. The first was serotonin syndrome, and the second one goes like this. There's a 22-year-old female who presents with multiple episodes of depressed mood, difficulty concentrating, sleep disturbances, etc., and 1 week ago you prescribed her fluoxetine. She comes back to your office saying her mood's not changed. The choices will ask you to say what you should do, and most will suggest either switching meds or adding another medication. Choice E will then likely say, provide her reassurance and ask her to come back in 4 to 8 weeks. It takes about this long for it to have an effect. The next two drugs we'll discuss belong to a class known as SNRIs, or serotonin norepinephrine reuptake inhibitors. They quite literally inhibit the reuptake of serotonin and norepinephrine, just like tricyclic antidepressants. However, unlike tricyclic antidepressants, they don't have as many side effects relating to non-serotonin or norepinephrine receptors, like for example the anticholinergic or alpha-blocking side effects that are seen with TCAs. This is a newer class of drugs, and the two common ones on the market are venlafaxine and duloxetine. They're used primarily for depression, but venlafaxine can also be used for patients with generalized anxiety disorder. Duloxetine can also be used to treat patients with diabetic peripheral neuropathy. These are the primary clinical settings in which giving an SNRI is the proper answer on a test, so if your brain is starting to feel a little full at this point, and if it's not, I envy you, I'd start with those two scenarios. The most common side effect to know for this class is increase in blood pressure, so patients with a history of poorly controlled hypertension likely would not be good candidates for this therapy. Other nonspecific side effects include stimulant effects, sedation, and nausea. MAOIs are another very old class of drugs. Their names are somewhat hard to remember, but they include phenelzine, phenylcypramine, isocarboxazid, and selegiline. The last one, selegiline, is actually a selective MAO-B inhibitor, and will be discussed in more detail when we go through Parkinson's medications in the neuro chapter. The mnemonic we came up for these was Mao takes pride in Shanghai, for all you history buffs out there. These drugs work by blocking MAO to increase levels of the amine neurotransmitters, norepinephrine and serotonin, as well as dopamine, so their mechanism is somewhat similar to tricyclics and SNRIs, though they work by blocking catabolism as opposed to blocking reuptake. A classic side effect is that they can cause hypertensive crisis when mixed with beta agonists or tyramine, which can be found in many foods, classically wine and cheese. This is a very high-yield fact to remember, as many test questions will feature a patient with depression going into hypertensive crisis after eating these foods. So remember, in addition to taking pride in Shanghai, Mao doesn't like wine or cheese. Also remember, MAO inhibitors can increase the levels of serotonin and can increase the possibility of serotonin syndrome if they're mixed with drugs like SSRIs or meperidine, and therefore it's contraindicated to use these two together. We've covered most of the commonly used antidepressants, but there are 4 more that don't fall into the classic drug classes, but that may still appear on your boards for one reason or another. They each have something distinct about them that makes them boards friendly. The first one is bupropion, which is an antidepressant that causes an increase in norepinephrine and dopamine, but through an unknown mechanism, which also means you likely won't be asked how it works. The key fact about bupropion is that it does not cause a decrease in sexual function, so patients who are doing well with SSRIs but are suffering from anorgasmia may want to try bupropion as an alternative antidepressant. As you may be aware, it can also be used for smoking cessation. Other toxicities are more nonspecific, particularly stimulant effects and headache. It's also known to decrease the seizure threshold, specifically in bulimic patients, and is therefore contraindicated in this group. The next drug, mirtazapine, is an alpha-2 antagonist. It increases the release of norepinephrine and serotonin as a result. It also antagonizes 5-HT2 and 3 receptors directly. In terms of toxicity, it causes sedation, increased appetite, weight gain, and dry mouth. Basically, mirtazapine can make you fat and lazy. The first of these, sedation, is actually why mirtazapine is often the drug of choice for people with depression and insomnia. Meprodoline is a less often used drug that's known for causing sedation and orthostatic hypotension, but the chances of it showing up on your exam are probably fairly low. Trazodone, on the other hand, is a step 1 favorite. As we discussed earlier, it works by specifically inhibiting serotonin reuptake. While theoretically this makes it a possible treatment for depression, the dose required is often too high to be well tolerated, so incidentally it's become more commonly used for one of its other side effects, that is sedation. As a result, it's mostly used in patients who suffer from insomnia. Other toxicities include nausea, priapism, or abnormally sustained erection, and postural hypotension. Remember, anything that increases serotonin should theoretically cause widespread vasodilation.